Thank you very much. Chairman, ladies and gentlemen, it's my great pleasure to be here. And so when presenting a talk during a debate, it does give us the opportunity to take a slightly biased view of the literature in order to illustrate both ends of the spectrum and to, I suppose, encourage and explore debate. The first thing to say is that I've been asked to talk essentially about the case for preoperative chemotherapy as opposed to the case for preoperative chemoradiation in esophagogastric junction tumours. And if we go to the two studies that have been pivotal in determining the role for preoperative chemotherapy, we have to look at the MAGIC study, which came from the United Kingdom, and the French study from the FFFCD group, which both essentially showed similar outcomes for patients with the gastric and gastroesophageal cancer treated with systemic chemotherapy before and after surgery. In the case of the MAGIC, it was ECF. The FFCD, it was 5-FU and cisplatin. But it's quite clear that these are powerful studies supporting the role for systemic chemotherapy. And when we actually look at the impact of systemic chemotherapy in esophagogastric junction disease, what you can find is that there's a reduction in the rate of metastasis. And this is clearly of paramount importance in a disease which you'll hear about later, is essentially a systemic problem in the vast majority of patients from the point of diagnosis. Interestingly, when we looked at the MAGIC trial, the subset of patients which particularly benefited from systemic chemotherapy, if you look at the forest plot here and the hazard ratio, was in fact the OG junctional tumours. Now, the strongest case, if you like, for a preoperative chemoradiation approach has come from the CROSS trial, the Dutch study published last year in the New England Journal of Medicine. And this, of course, was a trial of preoperative chemoradiation in patients with adeno and squamous carcinomas of the esophagus and esophagogastric junction. And if we look at this study, we can see that 23% of those patients had squamous tumours, 75% had adenocarcinomas, and 32% were node negative, 64% node positive. And these are the very convincing results. So if you just look at this survival curve, you would say, well, here is a clear benefit from preoperative chemoradiation in this disease. Of course, this isn't one disease, this is two diseases. It's squamous carcinoma of the esophagus and it's adenocarcinoma of the esophagus. And I don't think that any of us would would take much convincing that these are different conditions, different etiology, and different sensitivities to drugs and to radiotherapy. And in fact, when you look at this trial in more detail, although the minority of the patients were in fact squamous tumours, it was the squamous cancer group that very much drove the survival in this trial. And then when you look at the separation of the curves for the adenocarcinoma subset, which is actually the majority of the patients, it's much less. So in this trial, the benefit was primarily in patients with squamous tumours. So I would say that this trial has definitely confirmed a benefit from preoperative chemoradiation in squamous tumours. We know that squamous carcinoma is a radiosensitive cancer. If you just look at histological path CR rates, it's about double in squamous as it is in adenocarcinoma. And certainly, We know that in squamous tumours, chemoradiation in some patients can obviate the need for surgery, and in our institution, it would be the primary treatment, chemoradiation, surgery only for those patients who fail to achieve a complete response. The case for adenocarcinoma, I think, is much less clear. And if we look at the forest plot within the cross trial itself, and you look at the subset analysis, the adjusted hazard ratio for the adenocarcinoma group is not significant. It's also not significant in the node-positive patients. It was quite interesting listening to that earlier talk about squamous carcinoma with the islands and pockets of disease, and you can see where that would very much lend itself to chemoradiation. So, in clinical practice, of course, at the esophagogastric junction, the vast majority of patients we see are the adenocarcinomas. And I would say that, does this trial represent a new standard of care? I'd say no, certainly not for adenocarcinomas. It wasn't sufficiently powered for that cohort. And in fact, in this trial, surgery alone, in many respects, was not an appropriate reference regimen. It may have been at the time the study was designed, but certainly by the time the study was reporting, most people had moved towards perioperative chemotherapy or post-operative chemoradiation. If we just look at things like systemic disease, this is an MD Anderson series showing that when you look for where these patients with adenocarcinoma of the esophagogastric junction and esophagus fail, they are failing in a systemic way. We don't yet have the more prolonged follow-up of the cross trial. So I think localized esophagogastric cancer is frequently a systemic condition. If we look at how we should use chemotherapy, we know from an advanced disease setting that using 2 drugs is better than using 1 drug from the various meta-analyses have been performed. Triplet chemotherapy, at least in the Cochrane meta-analysis, seemed to be superior to doublet chemotherapy, although there is some degree of equipoise within this area. If we look at the cross trial, I would say that one of my concerns is that if we are using this now as a new gold standard, then I think we'd have to have significant concerns about the exposure that these patients get to systemic chemotherapy. It's relatively modest. The drugs that were used in this trial were essentially given as radiosensitizing agents. And that's all very well if you have an exquisitely chemosensitive tumor, especially if it's node negative, it's localized disease, and it will undoubtedly benefit from chemoradiation, squamous, and I think the field abnormalities you heard about earlier on reinforces that case. And just in the last few minutes to say, 2 of my colleagues in the UK looked at 665 consecutive patients in 2 large institutions, my own institution, the Royal Marsden, and Guy's and St Thomas's teaching hospitals. And what they did was they looked at a series of patients many of them who'd had perioperative chemotherapy, but some for various reasons had not. And this is quite interesting data. If I just ask you to look at the curve as you look at it, the top left-hand corner there. And what this looks at is what the original stage of the tumor was and what the downstaged stage of the tumor was following chemotherapy, and they have then matched it to the group of patients who didn't receive chemotherapy for various reasons. So this is not a randomized trial. But what they've shown in this very clever and interesting analysis is that if you, for example, start off as a T3N1, your prognosis is as determined. If it's unaffected by the chemotherapy, so you don't get a response and you stay T3N1, your prognosis is as it would have been had you not received chemotherapy. But if you change that, for example, to a T2N0 or a T3N0, it assumes the prognosis of the better stage tumor. It's quite an interesting concept and one we need to bear in mind moving forward. So, finalizing, I think that R0 resections are important. Both chemo and chemoradiation downstage these tumours. Rates of path CR are important. Chemoradiation leads to reduced rates of local recurrence, but actually the key thing is to get better systemic control, and I think that's a very important objective in our oncological practice. Thank you very much.